Hello, Anil. Everybody has joined, eh? Hello. I'm not showing my audio. Are you able to hear me?
Yes, sir, we can hear, sir.
Okay, okay. So who else are joined? Paritosh has joined?
So he has not joined, sir.
And who else is supposed to join? I think
Madam has joined.
somebody.
Pragyan has joined.
Pragyan, madam joined. I saw. Sai Sudarshan
Sir, yes.
Hello,
also
sir.
joined.
Good evening.
Hi. How are
hello,
you?
Anil. Yeah, actually, I'm changing the laptop because the video is not working in this laptop. So I'll rejoin again.
Okay. Oh. How many participants?
अभी तो कम ही है सर. तो स्टार्ट हो रहा है.
Okay. Paritosh has joined. Hi man, how are you? Still operating?
अरे नहीं मैं थोड़ा सा I came to some other place to for some एक coiling करने आया था.
अच्छा जो भी किया कुछ तो कर रहे हो.
अरे क्या और क्या आप लोग पोस्टीरियर सर्कुलेशन को भी नहीं छोड़ते क्लिपिंग के लिए. छोड़ दो. हाँ जमाना खत्म हो गया. जमाना एकदम बदल गया है.
चलो
चल
हम लोग नहीं बदले तो कुछ भी नहीं मिलेगा हमको.
हाँ बताओ ऐसे थोड़ा
बदलना बहुत जरूरी है, नहीं तो ले जाएंगे सब. ऐसे ही कम हो गए केसेस आने. हेलो परितोष.
हाय हाउ आर यू?
Yeah, I am good. You're still working?
अरे नहीं actually I came to some other place. I usually don't work this late, but I came to some other place to do a coiling. Somebody called me. तो मेरा एक गुरु करके है जो. तो इसलिए मैं अभी भी हॉस्पिटल. Guys, so I'm happily home and all.
अच्छा.
चलो ठीक है. Okay, I'll stop.
Yeah.
So still 2 minutes. Then we can start.
I think we should start.
Yeah, we can start, sir, now.
Okay.
A very good evening to all. On behalf of Cerebrovascular Society, I welcome all the esteemed panelists and speakers. So this is continuation of our tricks of trade in cerebrovascular surgery. And this time we are going to discuss posterior circulation aneurysm. And first, I would like to invite Dr. Pragyan, who will be speaking on anatomical pulse and basics in posterior circulation aneurysm.
Thank you very much, Anil. Am I audible?
Yeah, yes.
Okay, and I'll share my screen. Thanks for the opportunity to present. So I'll be speaking on basic surgical anatomy and basics of So can you see my slides? Can you see my slides?
No.
Okay.
No, we cannot see slides.
No, not seen.
Oh,
You can
so
share your screen.
1 second.
There is option share your screen.
Yeah.
You just click that.
1 second. No, just give me 2 minutes.
Yes. Good evening, sir.
Good evening, Anil. Good evening, Sai.
Hi.
Sir, good evening.
Hi.
All good?
Going
Yeah.
along?
Good. Here in the theater, Sai, a lot of lockers in the
No,
background.
I'm at home.
Okay. Cupboards and a lot of.
Yeah.
A
This
lot of
is where Sirisha keeps working.
Oh, okay.
Traffic is so horrible in Hyderabad, so I came back early.
I know. Yeah. It's everywhere. It's very hot also. No rain.
Yeah.
What happened? It's not showing.
Yeah. I'm just loading into my Google Drive. Give me just 2 minutes.
Yeah, am I audible now? Okay. Great, thank you.
You're audible, but screen is not displayed yet.
Hi, Mathew.
Hi.
Still in the hospital?
I just came back. I got very fine.
Pragyan, some issues. Should we ask for some of the next speaker to speak?
I'm talking with Anil. Give me 2 minutes.
Okay.
मैकबुक से तुम्हारा जूम में शेयर करने के लिए कुछ प्राइवेसी स्क्रीन शेयर करना पड़ता है क्या कुछ? शेयर में कर लिया मैंने। शेयर में करके क्या करना है? हाँ हाँ, डेस्कटॉप 1 में किया मैंने, शेयर कर दिया। उसके बाद उस पे आ रहा है ओपन सिस्टम प्रेफरेंसेस, सिक्योरिटी एंड प्राइवेसी टू ग्रैंड एक्सेस। तो मैं विंडोज से प्रेजेंट कर रहा हूँ। 2 मिनट दे दो, मैं दूसरा टाइप। हेलो,
Anil, shall we?
I think better we take up with
Second talk, yeah.
Mathew, can you start?
Anil?
Yes, so you should ask the second speaker to start his talk.
Hello.
Mathew,
Shall we start with Matthew's talk then?
Okay.
So Mathew sir is starting, sir. Stop.
Okay, then I guess we are
Visible?
Yes, sir. Yes, sir.
visible. Slides are visible.
Okay.
So I guess I'll just give a brief introduction. I'm afraid we are just switched the order because of some technical issues. Ideally, we should have had the anatomy talk first, then followed by the surgical one, and then a comprehensive outlook of surgery versus intervention. Nevertheless, we'll switch over to the surgical aspects first, and for describing surgery for posterior circulation aneurysms, we have one of the best vascular surgeons of the country right now with us, Mathew Abraham. And Mathew had his long career in Sri Chitra, where he did his residency, then continued there as a faculty to become the president, to become a professor. And right now he is with Lissi Hospital Ernakulam. And I guess he has a unsurpassed experience with aneurysms of all varieties, anterior, posterior, and all complex and giant aneurysms. I welcome you, Mathew, to share your experience with posterior circulation aneurysms. Over to you, Mathew.
Thank you, Dr. Girish, for the sweet introduction. Dr. Girish is responsible for teaching me most of the tricks of the trade. I'd also like to thank the organizers for giving me this opportunity. Today, my topic is posterior circulation aneurysms, management and issues regarding that. If you see, 8 to 13%, and in some series of 16% of all intracranial aneurysms are of the posterior circulation. Probably because of the depth, it is considered technically difficult by surgeons. The total trajectory available is comparatively narrow when compared to other aneurysms. It presents usually in the 5th and 6th decades of life, is more common among females as in case of any other aneurysm. It may be saccular, fusiform, or it may be a dissecting aneurysm. There are several shocking aspects when it comes to a posterior circulation aneurysms, which we probably know, but we may not notice to that extent. The risk of rupture is 1.6 to 4 times higher. If you take all the meta-analysis of most series, you will see that everywhere the average risk is 2.5 times higher than aneurysms to anterior circulation. And still more shocking is that the survival after rupture is only 32% for a posterior circulation aneurysm, while for an anterior circulation aneurysm is 77%. So it's more than twice as risky. They are 4 times, 2.5 times more, there's a chance of a rupture. And the survival is also only half. And the survival after 30 days of a posterior circulation aneurysm rupture is just 11%. That is mostly a fatal disease versus 53% for anterior circulation lesions. 53%, that means half of any aneurysm that ruptures dies ultimately. But in the case of a posterior circulation aneurysms, approximately 90% of all aneurysms and ruptured aneurysms can be expected to die. So there is a grave scenario when it comes to a posterior circulation aneurysms, and hence the great need for treating them. And also, there's a 10% chance of sudden death in case of aneurysms rupture, while in case of a basilar aneurysm in specific, the chance of sudden death is 21%. Now, let me briefly tell you why surgery still is the most effective choice. The risk of significant recurrence after aneurysm coiling, any aneurysm, let it be anterior or posterior circulation, is 20%. In some series, it has gone up to around 27%, while in some series, it may be around 18 to 19. But the average meta-analysis, this one shows, around 20% of any coiled aneurysm recurs. And the chance of undergoing retreatment is 10%. That is, those which reach a proportion that they may rupture is approximately 10%. And the chance of recurrence after surgery is interestingly 3.5%. That is, you find a significant aneurysm in 3.5%. And the chance of retreatment after surgery is just 1.2%, which simply means surgery is around 8 times more effective with regards to prevention of retreatment. And the risk of significant recurrence after coiling of a posterior circulation aneurysm. Again, there are so many adverse, this is again another adverse factor when it comes to posterior circulation. There is 30%. There are a few series which say that around 57% of, around 43% of posterior circulation aneurysms show significant recurrence. And interestingly, any recurrence, all these significant recurrence in the case of a posterior circulation aneurysms, those that warrant retreatment. So here is again a case for surgery. When it comes to a favorable aneurysm, the chance of eliminating, and the patient being young, the chance of eliminating an aneurysm is certainly highest when it comes to surgery. When it comes to posterior circulation aneurysms, it's dominated by the basilar top. There is 45 to 55% of any aneurysm of the posterior circulation is likely to be a basilar top. Followed by the, we all know the superior cerebellar aneurysms are the next common. The pica, when the pica, vertebral artery junction aneurysms are the next. And followed by distal PCA or PCA aneurysms, P2, and the lower basilar trunk aneurysms and IK aneurysms. When it comes to posterior circulation, there are 3 vascular territories that we have to be aware of. Basilar apex, that is which includes the basilar bifurcation, the posterior cerebral artery, the superior cerebellar artery, all those structures that come about, the basilar artery, superior cerebellar junction, and the upper basilar artery. This is the vascular territory of significance when it comes to the basilar apex. Then comes the basilar trunk or the middle segment, which is actually less accessible. The IK aneurysms and the mid-basilar are on the ventral side, and the vertebral trunk, those that arise in the vertebral artery, the pica, and the vertebral basilar junction. So these are the 3 segments that we are concerned of. Within this 15 minutes, I think I will concentrate on the basilar aneurysms. The concept and the very principle, the surgical, the nuance of approaching these aneurysms. We all know there are 3 options. When it comes, as I said earlier, complex aneurysms are the chance of total elimination of aneurysm, a complex aneurysm from coiling is relatively low. And when there is spasm to access vessels, the need of surgery becomes increasingly emphasized. When there are aberrant vessels and a patient choice that is in a patient who is young, and most importantly is the availability of expertise. Posterior circulation aneurysms are not for a novice surgeon. They're not for somebody who do not do it regularly. They require significant baseline training in other aneurysms before one can attempt posterior circulation aneurysm. If you look at the approach towards basilar aneurysm, they're forming in two categories. You want to go as low as possible. That's a subtemporal approach. The approach popularized by Drake, and the transsylvian approach, that is the approach that is the more popular, and around 75% to 80% of all aneurysms are approached through a transsylvian approach. Now, these are not exclusive things. We all know we are trying to reach the same target, and we have an anterolateral trajectory. So you can combine these approaches, and when you combine, two variations come, the half and half approach. So what's a half and half approach? It's very relatively simple. Along with the Sylvian approach, you also use the subtemporal approach. So what do you require to reach the subtemporal after a radical Sylvian opening? You have to cut the sphenoparietal sinus. Once you divide the sphenoparietal sinus, the temporal pole becomes more mobile. Once the temporal pole is mobile, you can retract it further posteriorly and maybe further enhance with a cut on the tendorium to combine the Sylvian approach with the subtemporal. So that's a half and half approach. And then you have the cavernous extension. When you hear transcavernous extension, we may think it's just a simple variation, where after you make an extradural mobilization of the interdural plane of the temporal lobe, then open the dura and combine the extradural and intradural exposures, dissect the third nerve into its cavernous sinus. You get an additional few millimeters, around 3-4 millimeters of extra basal access.
Hello.
And more anterolateral access. A pure Sylvian approach has several assets to it. It is familiar because most people are used to anterior circulation aneurysms. And to graduate from an anterior circulation aneurysm to a posterior circulation, you need a more familiar approach. So to start off, this is the approach of choice. The main advantage is a proximal control is straightforward. You directly look at the basilar artery before you see the aneurysm. Both PCA segments are most often seen, except when the location is, I shall come to that later. And so this is the transsylvian approach, is an approach where you can actually trap the aneurysm. We can get proximal as well as the distal flow, so that if there is an abnormal bleeding, you can always put the aneurysm under control. And it is a wide approach, and it can be further enhanced. I shall come to the enhancements later. So the essential aspect of a basilar approach is to get access to the aneurysm as well as be capable of enhancing the exposure as much as possible. The cone of access can be extended more liberally when it comes to a transsylvian approach. It has some problems also. A transsylvian approach has several issues associated. The main problem is the perforators. The perforators, which are sometimes asymmetric in location, those that come towards the brainstem, that is, which come posterior towards the brainstem, are blind. When you look from the anterolateral angle, you will find that the perforators going towards the brainstem are comparatively blind. So, if it is a posteriorly projecting aneurysm arising from the basilar apex, you have some little amount of delay until you have completed the treatment. And you may require a reapplication key for perforators. So the clip being put from lateral, the tip is relatively blind. So this is not a great approach when it comes to posteriorly projecting as well as a really anteriorly, truly anteriorly, but it is an excellent approach when it comes to an upward projecting aneurysm. So my advice to the juniors is choose your aneurysm before you go start a basilar. Don't choose a posteriorly projecting or an anteriorly projecting, a high riding or a low riding aneurysm as your first one. It may give you a demoralizing experience that you may not touch another basilar top again. So the sweet basilar tops perhaps may have to be chosen, and you will find that the Transylvian approach, getting a anterolateral top-on view towards the basilar aneurysm will make you confident in tackling more and more difficult problems later. The second approach is a subtemporal approach. I know I cannot cover all these approaches, nor I find that this time may not be adequate to make a video demonstration of this. A subtemporal approach offers a surgeon many advantages. It will give you the main advantage is that you end on the body of the basilar vessel, so you can have a proximal control. But the distal control is actually the PCS are not very clearly visible. The perforators are the biggest asset. You can see the perforators in front of you. The approach directly coming particularly low gives you a direct view of the perforators, especially the perforon. You can enhance the approach by a tentorial division. It is an approach which is very suitable for fenestrated clips, and in comparison to the Transylvian approach, the corridor is narrow, but it is more end-on, and you can have a rotational view of the aneurysm. The narrowness of the field, the disadvantages of the subtemporal approach, because of the narrowness of the field, you only have a transverse control, vertical up and down control of the field is comparatively less. The P1s are not accessible. The P1s, maybe the ipsilateral P1 may be accessible. The opposite P1 becomes particularly difficult. And at the tentorial edge, as you enhance this one, or in case you have you require more exposure, the third nerve palsy is there's very significant risk of third nerve palsy actually for a subtemporal approach. So this is the crux when it comes to assessing how you must approach an average aneurysm. You should get a lateral view of the skull base. The sella is the key. Relative to the sella, you will be able to access, you will be able to read how the aneurysm is going to look when you open it. Of all the aneurysms of the brain, it is a basilar aneurysm where you have to be mentally prepared. You should have an idea of what you're going to expect, what you're going to see. Sorry. Now this is the picture. This is the range. If you want to go for a Transylvian approach, you have to get the mid-Sylvian point, the mid-cellar point. From the mid-cellar point, as well as the from the posterior clinoid, the aneurysm must be in the range of 1 centimeter. That is aneurysm neck. If the neck is more than 1 centimeter, it becomes a high riding, and you will require some additional enhancing procedure to get access to it. If it is below, a subtemporal approach may be better. But approximately 70% of all aneurysms, neck will fall within this ratio. Now there are 3 corridors. I'll rather focus on a Transylvian approach because I think that may be the first one when it comes to a student. This is the 3 triangles that are available. you can see that you have triangle 1, which is our routine opticocarotid space. We are all familiar with that. Every craniopharyngioma we will, or any lesion in the suprasellar region, we will use this. But unfortunately, this is not enough. This triangle 1 does not give you much access to a base. It will, unless it is a high riding or a very anteriorly projecting, this triangle is not very used. Now you have triangle 3 that is quite accessible after a wide opening of the sylvian and a good frontal retraction. You can see 3. This unfortunately has another problem. You have all the perforators arising from the MC and ACA coming in the way. But this is a reserve corridor in between where you can visualize. Although it may be difficult to apply a large clip to it, it gives you adequate space to visualize the most high riding baselars are seen well through this approach. The routine baselar is actually seen through this triangle number 2. The characteristic of triangle number 2 is the center point is the central figure will be the third nerve. Once you have a third nerve in the center, that means you have got this lateral triangle. So routinely, how do you reach the lateral triangle? There are several ways by which you can enhance and see this lateral triangle. We have, if you see, the temporal lobe is the one that comes directly in front. A small removal of the temporal uncus gives you wide access to this triangle number 2. And good release of CSF and adequate or elaborate dissection of the PCA. Now, suppose you are having some difficulty in accessing, there are several enhancements that are possible. So now on dissection of the deep dissection, the characteristic appearance, if you are adequately exposed, in the center of your field, the third nerve will stand. And just adjacent to that, you will find the third nerve is the key to the basilar top. It goes between as everybody knows, it goes between the PCA and the superior cerebellar. And once you can see the third nerve, you will understand the anatomy of the whole basilar top. It can be quite confusing. It can be rotated. You may mistake. The vessels may appear to be the same size. You may even mistake the basilar for one of the PCAs. And the superior cerebellar sometimes may be large enough to confuse you with the PCA. So the third nerve solves the issue. It will clearly tell you the orientation of all the vessels. And now, now, how do you further enhance? First enhancement, as I said, that is to expand the output. With a routine exposure lateral to the carotid, a relatively smaller baselars can be easily done. All the enhancement that you require is an uncus removal. Removal of the uncus and perhaps temporary medial mobilization of the ICA. You can retract the ICA with your assistant with a small retraction towards the left. The second enhancement is required as you find as the aneurysm is projecting away from you. Most baselars basilar top aneurysms are exposed from the right side because the non-dominant gives you an advantage of just deficits if you have a problem. But there is something peculiar about the basilar top. It is one aneurysm where there are specific advantages of going towards the side of projection rather than the side of the vessel, proximal control. Because you get a better orientation for the clip placement if the aneurysm is facing you. This is one contradiction when it comes to clipping of a basilar aneurysm. Although proximal control is very important, a better clip placement position is obtained by going towards the fundus. The fundus first approach has advantages when it comes to basilar. Now, there are several variations that can be seen. we can have the high riding basilar aneurysm. That is the aneurysm which is going beyond the ICA and the neck hiding behind the ICA. Now, how do you access? How do you get control on the neck of the centers? Two approaches. One is to go through triangle 2, that is between the ACA and the MCA. But you may occasionally have a problem with one of the MCA or ACA perforators. So you can work between them, good. But injury to these perforators can give you an unexpected deficit. Now, the second enhancement option that you have is to divide the PCA. The PCA, where do you divide the PCA? The PCA is best divided and divide the PCOM. The PCOM is best divided at the point where it joins the PCA. And if you divide the PCOM at that point, you get better control on a high riding basilar aneurysm, particularly towards clip placement. The next possibility is a low-lying basilar. Now, the low-lying basilar is the second major problem, and the low-lying basilar is often the deadlier of the combinations that you can have because of an absence of proximal control, and a panic clipping becomes very difficult because the posterior clinoid deflects your clip, and the clip may actually deflect upwards, fall away from you. And the low-lying basilar also gives you a difficulty in accessing the opposite PCA. Not only does the opposite PCA have a problem, the low-lying basilar is also associated with perforators which stick onto it, which travel a long distance along the aneurysmal wall. So when you have a low-lying basilar, the better approach is it's maybe perhaps better to avoid the transsylvian and go for a half and half approach or a transcavernous approach. And rarely you can have an extremely high basilar. I shall come to that a little later, which goes into the third nerve through the lamina terminalis into the third ventricle. So basically the enhancements, I shall come briefly to the enhancements that are possible. One is an orbitozygomatic osteotomy. The orbitozygomatic osteotomy gives you a more direct vertical access into the carotid triangle, lateral to carotid triangle, and shortens the depth by approximately 1.5 centimeters. A 1.5 centimeter is a major difference when it comes to the access. The next this thing is to do an anterior clinoidectomy. The anterior clinoidectomy further enhances by approximately 5 to 7 millimeters. So this is the single piece clinoidectomy that is there. The anterior clinoidectomy not only reduces the depth, but also releases the tissues in the region as well as the ICA, which will permit the ICA to be mobilized more in a more medial direction. Clinoidectomy perhaps may be a very useful adjunct when it comes to a high riding basilar. This is a variation that I usually use, that is the single piece clinoidectomy. This is particularly simple. After breaking the root, the two roots of the clinoid, you need not shell it fully. It just peels gradually, it can be teased away from its origins. You can get a radical removal of the clinoid without within approximately the time duration that you will take will be 2 to 3 minutes for such a clinoidectomy. Now, this is the second enhancement that they are talking of. This is the posterior clinoidectomy. If you have gone through a transylvian and you find that the basilar is a low one, immediately you are choked for space for proximal control as well as to visualize even the neck. So this is a posterior clinoid. Posterior clinoid is a very soft bone. It is very easily drilled. It becomes mobile and it breaks off very easily. It only blocks, it's seldom adherent to any structures. Only issues you'll have to drill it very close to the carotid and the third nerve. Drilling of the posterior clinoid will usually expose low-lying basilar. So the division of the PCOM, that is, it will increase the depth of your axis. And I think this is basically about all the aspects about accessing the basilar top. It is about fundamentally it is accessing the corridor lateral to the carotid and enhancing it through uncus, through removal of the uncus, anterior clinoidectomy, an increased, a wider craniotomy, a more basal craniotomy, maybe perhaps division of the PCOM, and if required, removal of temporal pole, division of the veins in the anterior part, retraction, posterior retraction of the temporal pole. So a preparedness to increase the axis as well as the variations is important when it comes to DV. Thank you.
Thank you, Mathew, for an excellent demonstration of the surgical techniques regarding to basilar aneurysm, and I fully endorse your view. Although Paritosh and Sai here might have a different opinion, your preference for surgery for aneurysm is something which I also share. Although it's a challenge while operating, once you do it properly, there's nothing superior to a properly clipped aneurysm. Anyway, let us not go into the debate for clipping versus coiling. We just wanted to elaborate on a few other aspects, which because the topic was posterior circulation aneurysms in general, because we put all of them together in one basket, and the moment you say that it's a posterior circulation aneurysm, we tend to look towards the endovascular surgeons. But basilar, of course, as you demonstrated so very well, it's a challenging and a difficult aneurysm where you have to have multiple approaches. But for a beginner, I would say distal pica aneurysms is one of the easiest of aneurysms to clip because you've got nothing to lose. Similarly, the superior cerebellar aneurysm through a transylvian approach is fairly an easy aneurysm to clip. Similarly, a vertebro-pica junction aneurysm, especially if you can have a far lateral approach, even through retromastoid, but if you are not too comfortable, I have a lateral approach. These are relatively straightforward approaches, especially vertebro-pica, because you have a proximal control, although from all vertebral aneurysms, you will have crossover from the other vertebrae, so there will be some flow, but they are generally easily accessible. So generally this tendency, the moment that you hear a posterior circulation aneurysm, the tendency to look for an endovascular option is not always required because, as I said, some of these are very easily clippable aneurysm with excellent outcome. Basilar aneurysms, as you told, you need to have some expertise, not some, I mean, very good expertise, especially for the various options that you described after the primary two approaches, that the transylvian and the subtemporal approaches. Then you need to have multiple variations and your skill on clinoidectomies, both anterior and posterior, are so very important. Thank you, Mathew, and I'll leave to the other panelists if you have any other suggestions and thoughts on this.
Nothing. One thing I want to add up. Not all people are gifted like you and Mathew with clinoidectomies and exposures. So that is why the tendency to send them off for endovascular is much more.
No, basilar accepts.
Other thing is how many cases you see in your career in practice. So it's the question of toying with the life of the patient than taking it as a challenge, actually.
No, basilar, I perfectly agree, Sai. I was talking about there are like this, when you put all of them together in one basket and say posterior circulation aneurysms, basilar top aneurysms are challenging aneurysms. And
no, they are challenging even for endovascular as well. Sometimes if you see both the PCAs arising from the neck of the aneurysm, then you may have to go for augmented things like putting a stent across or making an intrasaccular device and all that. Anyway, let us not waste time. We can call the first speaker now. Can we call the first speaker? Pragyan, are you ready?
Yes, sir. He's sharing his screen, sir.
So can you see my screen now?
Yeah, we can see.
Okay, thank you very much. Sorry for the technical glitch and my sincere apologies. So yeah, so my task has been made easy by an excellent demonstration by Dr. Abraham as usual. So I'll be skipping the slides which are common and giving common information. So we all know that the posterior circulation aneurysm consists roughly 15% of the intracranial aneurysms, and surgically they are very difficult to tackle, and it has a long learning curve. And in present era of endovascular practice, the indication to openly for open surgery in this kind of aneurysms are getting fewer and fewer, and therefore the surgical anatomy, whenever the need arises, is very important. So we basically, when we call about posterior circulation aneurysm, we basically talk about three vascular territories. The basilar apex, which is again can be subdivided into basilar artery bifurcation, PCA, SCA, basilar artery SCA junction, and the upper basilar artery. Whereas when we deal with basilar trunk, it mainly deals with mid basilar artery and the ICA. And lastly, the vertebral trunk, where the aneurysms can also arise from vertebral artery, PICA, the vertebral artery PICA junction, as well as the vertebral basilar junction. So this is a schematic diagram of all the sites which I have already mentioned, and they can, as I have already mentioned, can be divided into three categories depending upon the location of the aneurysm. Now again, the aneurysm can be secular, fusiform, and as already has been described, the size of the sites of most common size of secular aneurysms are most common is the basilar apex, but they can be seen anywhere in the posterior circulation, whereas in fusiform aneurysms are mostly occur in association with intracranial atherosclerosis and can be encountered most commonly in vertebral arteries. We also can see sometimes dissecting aneurysms, with the most common site being vertebral artery, which can be traumatic, and lastly, dolichochoitic aneurysms of the vertebral and basilar arteries can also result from dissections that produce fusiform degeneration. Now, it's important to remember, and it's important to understand that whenever we are dealing with posterior circulation aneurysms, the anomalies, the incidence of anomalies are usually higher than what we encounter in normal population. The most common anomaly, which is quite commonly seen and quite commonly encountered, is a fetal origin of the PCA. However, there can be also carotidobasilar anastomosis, and hypoplastic P1 is also one of the common anomalies. So this is a schematic diagram of what we understand by fetal origin of the PCA. As you can see, the top figure is the normal anatomy and normal anatomy, where the caliber of the PCA is quite large. Whereas in the second slide, the PCA is absent on the right side and is mostly supplied, and it arises from a PCOM artery taking origin from ICA. And in this case, the last case, where you can see it's the overall caliber of the PCA is very small, but the main blood supply is again coming to the ICA and bleeding and ultimately supplies the PCA, which is what we understand as fetal PCA. These are the radiological images where we can clearly understand what is usually described by fetal PCA, as you can see here quite clearly. Now, it's also important to understand that unlike the anterior circulation aneurysms, which always follows mostly, which majority of the cases, vast majority always follows the anatomical principles of aneurysms being arising at the apical branching site of the major vessel and point in the direction of the blood flow, which have followed had the curve been not present. In posterior circulation, mostly in superior cerebral and ICA and vertebral aneurysm, which is not so. The main reason being these vessels are very tortuous, and the aneurysms point in the direction of the blood would have gone had there been a the curve was not there in the origin of the involved branch. Now, there are certain anatomical principles which remain the same, irrespective of whether we deal with anterior and posterior circulation. The parent artery should always be exposed, basically for proximal control. And for basilar apex aneurysms, as has already been nicely demonstrated, we need to follow the inferior surface of the PCA or the superior surface of the SCA to lead to obtain proximal control. Also, the side of the parent vessel, we should dissect away from the opposite to the side where the aneurysm is there. Also, it's a common practice and it's an open secret that we should always dissect the aneurysm neck. Although, unfortunately, in posterior circulation, neck can sometimes incorporate the origin of the parent arterial trunk and sometimes also the perforators. So the key to outcome of posterior circulation aneurysm, of course, it has a long learning curve, and at the initial stage of our surgery, we are always concerned about not rupturing the aneurysms during the surgery. But actually, the main outcome of the surgery depends upon to what extent we are able to preserve the perforators and not related to actually even if the aneurysm ruptures during the course of surgery. So there are different strategies which has been described in literature, which can lead to increased rate of perforator patency. The commonest strategies can be lowering of the blood pressure, leading to which enables the surgeon to dissect well. There can be we can always resort to temporary clipping. Sometimes we can, in rare cases, we can push a temporary clip around the middle portion of the parent artery to reduce the width of the aneurysm, and therefore, by making it easier to dissect the perforators. And sometimes when we are clipping, we can take the perforators in a fenestrated clip, or we can use an endoscope to visualize the thalamoperforating vessels and the major perforators to avoid taking them in the clip. These are the major surgical strategies. Now, the basilar trunk aneurysms, the basilar trunk aneurysms at the level of the superior. I am only mentioning the key points because while Dr. Abraham was presenting, I have deleted some slides. So the basilar trunk aneurysms at the level of the SCA, they often arises where there is a curvature and tilt of the upper basilar artery, so that the hemodynamic thrust is just above the origin of the SCA rather than the basilar apex. This is very important point to remember. Also, we should know that the aneurysm located at the origin of the anterior inferior cerebral artery usually arises from the convex side of the curve of the basilar artery, and they always point to the direction of the long axis of the basilar segment immediately proximal to the aneurysm. So the most common aneurysm site in vertebral artery is at the level of the origin of the pica, and there is often being depicted in angiographic images. Vertebral artery is often depicted as being straight and appreciated as straight, whereas whenever the pica arises, it always has a convex upward curve. Also, the aneurysm usually arises from this apex of the curve and at the origin of the pica and usually point upward. Further, we should know that aneurysms arising infrequently at a junction of the two vertebral arteries with a basilar artery may always initially seem difficult to fit into these percepts. So these aneurysms often arise at the convex side of a tortuous curve formed by the vertebro-basilar junction. Now, as we know that the most common aneurysm in the vertebral basilar system are the basilar perforation aneurysms, and they usually project upward. And the surgical strategies may vary. It has already been described depending upon whether the bifurcation is high up or lower up. Some anatomical key points to remember is that the PCOM can be hypoplastic, and it's a common practice sometimes when we are undergoing clipping of the basilar artery to sacrifice the PCOM to have a better view of the aneurysm. However, the number of diameter of the perforating vessels always remain constant regardless of the size of the hypoplastic PCOM. So always the sacrificing of posterior communicating artery should be resorted to a rescue option and should not be routinely practiced. As I've already showed in the previous slide, that the outcome of surgery mainly related to what extent we are able to save the perforating arteries. And in this context, it's important to remember that the thalamo-perforating arteries are very important vessels, and we should take particular precaution to not take them in the clip while clipping the aneurysm. Also, in basilar perforator aneurysms, it's important to know that the location of the major perforating vessels are always posteriorly located, not anteriorly. So therefore, the more the posterior of the aneurysms, the more the chances of getting the perforator vessels injured, and therefore the prognosis become worse in proportion to what extent the aneurysm is located posteriorly. Distal PCA aneurysms can sometimes become larger, and sometimes they can mimic neoplastic muscle, which is well reported in literature. And surgical indications has already been described. I am skipping the slides. So these are the cadaveric pictures where we can see the difference of exposure between the subtemporal approach and also when we approach a basilar artery from a frontotemporal approach. As you can see, in the subtemporal approach, when we are cutting the tentorium cerebrally, we always have an excellent exposure, and this approach is particularly useful, as already shown in the slides and the video demonstration in the previous presentation. So these are basically the difference of exposure between the subtemporal and the frontotemporal standard frontotemporal and trans-sylvian approach. So this is another schematic diagram where anterior subtemporal exposure is being done for a basilar aneurysm, which is arising at the origin of the SCA and the posterior cerebral artery. And lastly, this slide is another schematic representation of anterior subtemporal exposure for an aneurysm which arises at the origin of the ICA, as you can see here. And the cutting of the tentorium cerebrally can improve the exposure greatly in this kind of in this approach. So these are again schematic diagrams of the anterior and middle temporal approaches. I am not going into details because this already has been explained in great details in the previous presentation. However, it's important to remember that the cranial nerves are very closely located to the overall exposure, and it's important to preserve them and during the course of surgery. So this is the other standard approach is the frontotemporal craniotomy and trans-sylvian approach. And when we are talking about this craniotomy, we usually have four operative routes which we can take to arrive at a basilar apex aneurysm. The standard is, of course, the frontotemporal craniotomy and the trans-sylvian route. The basilar apex can also be approached through the opticocarotid triangle. And the main indication of approaching this aneurysm through an opticocarotid triangle is when the internal carotid artery and the initial segment of the ACA are long, which provides a very wide opening through this triangular space, and then it makes the access to the aneurysm easier. We can also approach the aneurysm through the interval between the carotid bifurcation and the optic tract. And this approach, unlike the previous one, can be used whenever the length of the carotid artery, internal carotid, is short than the average values, and it can lead to an easy access to an opening between the bifurcation and the optic tract. Lastly, we can also approach the basilar aneurysms which are directed by going behind the carotid artery and above the posterior communicating artery through the interval between the carotid and the oculomotor nerve. These are the different the four routes which I have already described. And as you can see, we can we can approach this aneurysm through four corridors when we go through basically the frontotemporal craniotomy. So the location of the perforators is a very important aspect, and we should always be well versed with the anatomy of the perforators when we are going to clip a basilar perforator, basilar aneurysm. The most common location, as you can see, the perforator is the posterior aspect of the artery, and therefore, as already mentioned, the prognosis of the aneurysm, the technical difficulty of the surgery is always significantly increased whenever the aneurysm is located posteriorly. However, there are wide variations of perforator arteries, as we can see here. We can see them in all configurations from both vessels. Sometimes they arise from the ipsilateral PCA also, and the contralateral PCA, and we can see a wide range of different presentations regarding the location of the perforators. Now, orbitozygomatic and extended orbitozygomatic approach is again can be employed, which is nothing but basically an extension of the radial approach by removing the superior and the lateral portion of the orbit, and we can obtain a higher view of the basilar apex above the posterior clinoid process in this approach. The inferior exposure in this approach is basically by removing the three interdural bony obstacles, the anterior clinoid, posterior clinoid, and sometimes also dorsum sella. Drilling the clivus can also be artery. And this is the basically the anatomical demonstration of the orbitozygomatic approach. This is what you can see. This is a standard craniotomy. This is the extent of the bony removal, starting from anterior clinoid to posterior clinoid, and depending upon the location of aneurysm, we can undertake different degree of removal for better exposure of the aneurysm. As you can see, this is the final exposure after we remove the bone, and the anterior. This is the final picture where the anterior clinoid process has been totally removed to expose the clinoidal segment of the ICA and the roof of the cavernous sinus, and also the adjacent part of the dorsal sella has been removed here to expose the basilar artery beyond the neck of the aneurysm. So there is another approach which can be undertaken, although the indications are very few, is the what you call as extended middle fossa approach, well reported, which was popularized by Kawase. It is nothing but temporal craniotomy with extradural mobilization of the temporal lobe, and followed by drilling of the petrous apex in the Kawase's triangle. This approach basically helps to approach the aneurysm from the anterior and the superior trajectory. And the main advantage is the hearing preservation. So again, the transpetrosal approach is also described, which can be categorized to lateral labyrinthine, trans, and transcochlear. And as you can see, in lateral labyrinthine, the main advantage being hearing is preserved, which is not so in translabyrinthine. So this is the anterior petrosectomy, which is a schematic diagram showing that this is the exposure of the skin incision and the craniotomy. This is the extent of the bone which is required to remove when we undertake this approach, and we can incise the tentorium. This is the tentorial incision. Tentorial incision is important to preserve also the fourth nerve while we incise the tentorium. Third nerve is also closely associated. And finally, after the tentorial incision and the dura has been opened and the trigeminal nerve has been depressed, we can get a nice view of the aneurysm. So we can also do far lateral approach, mainly in aneurysms. So it's in fact the most common surgical approach to treat the aneurysms of the vertebral trunk. The position usually patient is position in lateral decubitus position with a hockey shape incision, and then this is the dural incision, and then the vertebral artery and the lower origin of the pica here we can well appreciate in this diagram. And the aneurysm usually projects between the pica and vertebral artery in front of the brainstem and the lower cranial nerves. As you can see here, this is the pica vertebral aneurysm, for which a far lateral approach is the ideal approach and can be considered. There can be combined supra and tentorial approaches also, where we can do two maneuvers for basically posterior mobilization of the sigmoid sinus and the division of the tentorium, and sometimes we can also divide the superior petrosal sinus. Particular care should be taken to preserve the vein of Labe, and the main advantage being minimal brain retraction. These are the schematic diagram of the supra and infratentorial pre-sigmoid approach. This is the indicated, the commonest indicated aneurysm where we can undertake this approach. And the most common indications of this approach are aneurysms arising from the basilar artery at the origin of the ICA, the junctional aneurysm of the vertebral artery with the basilar artery, and all arises at the origin of the pica if the aneurysm is located high and deep in the posterior fossa. In all these indications are there, we can undertake this approach. The midline suboccipital craniotomy is usually done for bilateral vertebral aneurysms, for very distal pica aneurysms, as well as for bypass procedures. This is the exposure, as you can see. This is the standard exposure, where you can the right half of the cerebellum is being retracted here, and we can see the nice suboccipital exposure of the aneurysm in this diagram. There can be alternate surgical techniques which are not practiced in modern practice because we are leaning more and more towards endovascular practice, as we'll hear in the next lecture. However, there are very limited. These are the indications, although these are not commonly done. So cardiac bypass with hyperdynamic circulatory arrest is also described in all irrespective of the site when we get giant and complex posterior circulation aneurysms, where we undertake cooling of the brain and can be associated. However, it is important to remember that they can be associated with significant mortality and morbidity. Thank you for your patient hearing.
Sai, you are muted, I think, Sai.
It was quite unfortunate that we should have started your lecture first, then would have gone to the surgery. But anyway, better late than never. Any other comment you want to add, Girish? Or
No. Paritosh, is there? No, I think it's an exhaustive coverage of them.
Sir, there is one question. Will you advise from Aviskar? Will you advise during FTOs and osteotomy and all the basilar top aneurysm?
Mathew, can you answer that?
Yeah. FTOs, I have not. After one or two cases, I have never used FTOs. It is one of the few more millimeters, but I don't think it's very much necessary. What I felt regarding the advantages of an FTO is it can be obtained by a small uncissectomy. Roughly the same trajectory can be obtained if you remove a small portion of the others.
You mean to say clinoidectomy is better than FTO?
No. Yeah, clinoidectomy is definitely a shade better than FTO, is it? And a small uncissectomy. A small uncissectomy.
Okay.
Yeah, I agree with just a small transuncal approach, which I call just sucking out a bit of uncus.
I can understand, Dr. Girish. The people with surgeons with experience in epilepsy.
Surgery gives you an excellent just sucking out a bit of middle part of the temporal lobe. Saves a lot of time which you do in doing an FTO Z approach. If required, you can cut the tent and retract it also a bit, and then you have a very good approach there. But as emphasized by Pragyan, is that importance of the perforators. I guess in that area, one thing all surgeons need to be careful is none of those small perforators we can take for granted. No, not a single small vessel, either an artery or a vein, take for granted and need to preserve all of them. It's a very important part of surgery in that territory. Never know, some of them will be always supplying.
Paritosh, put your views.
Both of them have been very exhaustive things about things that we generally don't do nowadays. It's been years since we flipped basilar aneurysm now. As Dr. Girish said, of course, the other aneurysms may be easy. I only differ with it. Can you hear me?
Yeah, yes,
sorry
sir.
about the ambient noise.
Some disturbance from somewhere, I guess.
1 second.
Not yours, I think, Paritosh. I think.
No, it is mine only. It is somewhere mine. I'm outside. Sorry. Yeah. So what I was saying is that the only difference I have with Girish is that the vertebral pica aneurysms, those if you handle the lower cranial nerves, then they will lead to a poor outcome at 3 months. Now, all of them will recover, but the BRAT study, the most common cause of the failure of BRAT study, they say, is that most of the pica aneurysms were vertebral pica aneurysms were randomized to clipping rather than coiling, and that led to poor results. But other than that, I think SC aneurysm is a fairly straight shot. Distal pica, of course, is a straight shot. But yeah, I mean, in our practice, almost all aneurysms are treated with endovascular techniques that Dr. Anita will say. And endovascular techniques have really progressed much beyond coils and things, and that is probably the topic of Dr. Anita's lecture. So let me know.
Yeah, so just sorry to interrupt, just 2 points. Yeah, in modern era, as we all know, the indications of surgery in posterior circulation aneurysm has significantly gone down, rightly so. We have a vast literature now available where obviously the endovascular methods are more advised. But as neurosurgeons, I think everyone, including the newer surgeons, should be at least be aware and should know the trans-sylvian exposure and the subtemporal approach with anterior and posterior clinoid drilling, not only for basilar aneurysms, but these are important surgical skills which is often required to treat a wide array of neurovascular pathologies.
Thank you so much. Shall we move on to the next talk by Anita? Dr. Anita, can you hear?
Hello. Yeah, am I audible?
Yes.
Yeah. Shall I start off?
Yes.
Sure.
Actually, my video is not working, so pardon for that.
You want to show it as in a separate, you can always show it as outside the PPT.
There's some problem with the computer, I believe.
Okay.
Dr. Anita is the head of the department and director of neurosurgery, DIPMAT, New Delhi.
Sir, video is working in the presentation, but madam, that video is that
and last year she has organized a very good academically full conference. So, Anita.
Thank you, sir. Thank you, sir, for kind introduction. Yeah, so continue without wasting time. I agree with Pragyan that we should know the basic. One thing is that we should be hybrid. We should be knowing the open surgery as well as the catheter-based surgery. There's no doubt about it. But at the same time, we should be knowing the basic surgical skills also, and that includes clinodectomy, various exposures, various craniotomies. So, just going through the surgical strategy and how the endovascular treatment is good for posterior circulation aneurysms, covering the aneurysms other than the basilar top. So, when we are planning the treatment for any aneurysm for endovascular treatment, we need to understand that is the lesion accessible, the aneurysm is accessible. What is the relation of aneurysm with the perforating vessels? What is the relation of the aneurysm, especially for the posterior circulation, the posterior clinoid process, as Dr. Mathew Ibrahim elaborately described, and is what type of hardware you're using that will demand the use of or the necessity of dual antiplatelets when you're treating the aneurysm by endovascular method. Unlike anterior circulation aneurysms, the posterior circulation aneurysms, they are deeply seated, deeply located, and unlike anterior circulation aneurysms, the parent arteries, they are not so tortuous and abnormal, what you see in the aneurysms of the posterior circulation. That is the bigger difference between the two anterior and the posterior circulation aneurysm. So, what was discussed that posterior circulation aneurysms, the endovascular treatment is not so challenging. It may be very challenging if you see the parent artery through which your catheter is going and reaching to the target area. So this is very old picture which I took from the Rangachari, and where again the commonest location is basilar top in posterior circulation, next is superior cerebellar, then comes the pica, and then the basilar, mid-basilar or the vertebro-basilar junction. So if we see this this meta-analysis where they have used many gadgets, many hardware to treat the posterior circulation aneurysm. So first one need to know what all hardwares you can use to treat to treat aneurysm by endovascular means. So coiling is the most commonly used still for the posterior circulation other than basilar. We are talking other than basilar. So I'll be describing only everything other than basilar. So still the coil is the primarily which is most commonly used. Next comes the balloon assisted, then arterial occlusion, which is very commonly done because the aneurysms at the superior cerebellar artery or at the pica or ica, they are in the posterior circulation, they are majority of the time that it is dissecting aneurysms, and majority of time the arteries terminating into the aneurysm. So they may require arterial occlusion more frequently compared to the anterior circulation. Then vertebral artery aneurysm or mid-basilar artery aneurysm, where the neck is very wide, one may use the stent-assisted coiling. And of course, there are few reports about flow diverters and the stent. So if you see, when you are having an aneurysm, you have done the CT angio and you know that there is an aneurysm. So what is the next step? Next step is doing the angiography. For posterior circulation aneurysm, it is not that, unlike anterior circulation aneurysm, where you are sure that there is an aneurysm by the CT angio images, you are sure that there is only anterior circulation, where you can get away doing just only one vertebral angiogram. In posterior circulation, you need to do both VA angiogram because you may find this kind of vertebral artery. This so tortuous, this kind of basilar artery, so tortuous. Then you may find many anatomical variations. There can be fenestrations of the PCA, there can be fenestration of the basilar, there can be fenestration of the vertebral. So to decide from which side of vertebral artery, right side or left side, you want to go. So you need to have both the vertebral artery angiograms. Then next thing comes is you need to see where is the neck. Where is the neck? Means that unlike open surgery where you just see the neck, you dissect and you look for the perforators. Similarly, here also you find the best view, which is usually in the posterior circulation aneurysm, is the Townes view, where you can avoid both the petruses, where both the petrus just overlap onto the rim of the orbital margin. So and another bony obstacle is the mestoid. So these are the two bony obstacles which you need to clear. So you need to angulate the gantry of the C-arm or your catheter, that these two things does not interfere in understanding the anatomy. So you have to make a projection where you get to see the aneurysm, and you get aneurysm neck and the adjacent vessels as well as the parent artery. So that is a prerequisite to start doing any procedure, any intervention. And of course, you need to know which kind of hardware you use. For example, this kind of artery, it is very difficult to go with the routine guiding catheters like Envoy with a Cortis. And this kind of arteries will require distal access catheters, long catheters that we'll see in the few of the cases. Sometimes when you are planning the DSA, for DSA, majority of the time, still we are doing the femoral punctures, although people are shifting towards the radial puncture, but still neurosurgeons are more skeptical about the radial route. So, but for the vertebral artery, like if you are seeing this kind of vertebral origin, and this may be difficult to come from below through the arch and going like this and taking this big turn and all. It may be possible nowadays with a good catheters, but suppose there is dissection of the abdominal aorta. Then you cannot reach by the femoral loop in this. Then what is left to you? Either the radial approach or the brachial approach. So one need to know the different approaches to reach, to take the catheter to the target area, the femoral, the radial or the brachial. So depending upon the requirement, you can change your approach. Like this was the brachial artery cannulation. You see the humerus and all, and then the subclavian artery, and this is the origin of the vertebral artery. So this approach one should know that sometimes you may require to change the axis to reach to the area of interest. Then like pica and vertebral artery aneurysms, the pica aneurysm can arise from the origin of the VA pica junction. They can be distal pica aneurysm. Then they can be overlap of vertebral artery dissecting aneurysm, which is going into the pica. So you need to understand what is the origin of the pica aneurysm in relation to the pica. So if, as Dr. Mathew Ibrahim said, that these are the aneurysms which are reasonably can be handled by the open surgeries, but and of course the treatment is also, the outcome is also good in terms of the completeness of the treatment. But with new microcatheters, one can treat these aneurysms by catheters also. Then comes the superior cerebral artery aneurysm and ICA aneurysm. They make very small percentage of whole peak posterior circulation aneurysm. And again, as Dr. Matthews described very nicely, that they can be clipped because they are running into the cistern and they can be approached by the routine extended opening of the Sylvan fissure and can reach to the aneurysm. However, they can also be done by the endovascular method. Then next category comes is a dissecting giant complex aneurysms. They are definitely poor endovascular candidate for when in terms of the hardware choose. Like many a times, if the giant thrombos, they may require occlusion of the artery or the FD. Then in the vertebral artery aneurysms, they are usually dissecting aneurysms. They are better for the endovascular because either you put the flow diverter across the wall where there is dissection, or you occlude the artery if the other artery is good dominant and supplying the if the dissection is beyond the pica origin. So they can be better managed with the endovascular treatment without opening the skull. There are complications associated with catheter-based surgery. It's not that it is always 100% safe and foolproof. It's not the truth. There can be mortality because of ischemic stroke. They can be intraoperative rupture of the aneurysm. They can be perforated infarction. All these things are also associated with a catheter-based surgery. So if somebody wants to do so, you need to understand the anatomy. You need to have the expertise of ideally both the open as well as the endovascular, to understand what kind of treatment is best for that person, and to see the status of the rupture and availability of hardware. This is very, very important thing in any catheter-based surgery. So this is a vertebral artery, V4 segment aneurysm. You can see that this is very wide neck. It is almost more than the size of the vertebral, almost the size of the vertebral artery. So this kind of aneurysms cannot be treated just by coiling. They require stent-assisted coiling or flow diverter. This was the aneurysm, pica aneurysm. This is at the origin of the pica, and this is the distal pica. So this kind of aneurysm, it is difficult to take the catheter right up to this place. This may be good for the clipping, but this kind of aneurysm is good both for clipping as well as coiling, as this was done just by the putting some simple one coil. This is the vertebrobasilar junction. Here you can see that the origin of the pica is very distant. So when these are the aneurysms, posterior circulation aneurysms, they are majority of the time, they are associated with many anatomical variations. So you need to understand that. So it is, although it is a distal pica, a distal BB, but here you can say that it is pica, VA pica origin, VA pica junction aneurysm, and it can be done just with one coil. This was a patient which came to us in grade 4. Sometimes your machine may fail. That is what happened when this patient was admitted. Sometimes then we took this patient for the open surgery, and this was a giant aneurysm which was clipped and with a good result. Then this is mid-basilar artery aneurysm. These are two kissing aneurysms, and during the after the coiling of this one-sided aneurysm, when you are doing second side aneurysm, or the picture is not there, there was intraoperative rupture of the aneurysm. So when there is intraoperative rupture, you are lucky that your catheter is inside the sac. Don't take out the catheter. Keep coiling the aneurysm. That is what we did. And in fact, actually in this case, we got to know that there is fenestration of the basilar artery. So sometimes you get to understand that. Hello? Hello? Is it fine?
Yeah, madam, please carry on.
Yeah, so sometimes you get to know the actual anatomy after occluding and after getting the flow diversion, as in this case. And this was after 2 years of the surgery. And this is good fenestration of basilar artery seen and these two aneurysms. So many a times the anatomy is so difficult to understand if you do not have the 3D images, 3D cath lab. This is one of the case with superior cerebral artery. This is SCA and basilar artery junction aneurysm. And sometimes you feel that this artery is actually arising from the sac. But when you rotate and see the 3D view, then you will find that actually it is not arising. It may be somewhere adherent to the arachnoid of the along the side of the aneurysm, and you can coil these aneurysms. Now again, since with the more and more use of distal access catheter, long sheets, it is easier to take the easier to negotiate, track through the various curvatures of the vertebral artery, of the basilar artery. As you are seeing, it is lengthened but basilar artery. So it is good to take the distal access catheters. Another case where this is so tortuous vertebral artery and all. Yeah, sometimes if you're lucky, you can take the catheter without the distal access, as we could do in this case. Simple coiling of just putting 1 or 2 small coils, you are done, and the results are quite stable. Another case of right SCA, and there is small aneurysm at the PCA also. We just did 1 aneurysm coiling. This did bleed, so at one go, we just treated 1 aneurysm. So there are many variations you may find, not only anatomical, there can be multiple aneurysms also. Look at this tortuous, so bad tortuous artery. It was so difficult to understand from where the aneurysm is arising actually. So sometimes your microcatheter, what you are seeing the shadow here, the microcatheter guides you actually what is the origin of the aneurysm. And you can see that one basilar artery is supplying the whole anterior and posterior circulation. So for this kind of vessels, you have to be very careful. You have to be very careful with your anticoagulant, with your heparin infusions, and with your catheter handling, and the dose of the heparin to be repeated ACT measurements, and all those are very, very important for this kind of aneurysm. And single artery supplying the whole brain. This was one of the cases where we went through the brachial artery and again SCA junction aneurysm. So excess may be sometimes a problem in endovascular procedures. Again, one more case where the single basilar artery supplying the whole circulation and distal basilar artery aneurysm. You may find this kind of artery, you may find other side hypoplastic artery, one-sided dominant artery. So this is how you decide from which side, right side or left side, you have to approach the aneurysm. This kind of different morphology, small basilar, long basilar, abnormal, multi-lobed aneurysm, fusiform aneurysm. There are many variations which you find in posterior circulation, unlike anterior circulation. This is terminal basilar artery again aneurysm. Here it was looking like a basilar top, but that is what you need to take many views, or if you have 3D machine, it is nothing like that, and you will get to understand from where it is originating. This is posterior PC aneurysm, P3 segment. If you see, this is so morphology so different from other secular or fusiform aneurysm. This is dissecting aneurysm. For this kind of aneurysm, just keeping your catheter 2-3 centimeters away, then you can take a shoe, because even with 1 ml syringe and very slight pressure, you might land up in rupture of the aneurysm. So all these small nuances one should know, that it's not that you should be taking aneurysmogram in all the patients, which I'm going to show one case in the next few slides. And this is the super selective angiogram, which is showing that there is no distal flow. So this type of aneurysms can be occluded, and it can occlude the artery. This is something like one more aneurysm, and these are the aneurysms which can be occluded. You can get good results. This was a distal cerebral artery aneurysm. Now again, for this kind of aneurysm, you need to understand what hardware you will take. Hardware is very, very important in endovascular. Something like what scissors, what forceps you are using, what kind of microscope you are using. Here you need to know the hardware. So for this, since it is so long and you have to go so distal with so tortuous artery, so we took long sheath, distal access catheter, and even the microcatheter was, unlike 150 centimeter, the usual microcatheters, we took dual microcatheter of microvention. So one need to know various companies, what all companies are making, what all hardwares, and which hardware is best for of which company. So we took, which was 165 duos microcatheter, and we took the angiogram, and look, this is not the, unlike like an AVM, where you can have pseudo terminal AVMs. Something like this was pseudo-terminal aneurysm. So this was going here, and at the same time it was supplying the tentorial surface of the cerebellum. I thought we'll stop this, we'll not go ahead. But tried a small coil that let's see that where the coil is going, and luckily the coil went inside the aneurysm. But unluckily, I thought we can take a super selective shoot. That do we really need to put one more coil? And this is what this happened. So even the so distal segment of cerebral artery can rupture just by 1 ml, very slow injection, and you can land up into this kind of trouble. And this may require the occlusion of the whole trunk. So aneurysmogram is to be done very carefully. Don't do if you feel that you can get away without taking the aneurysmogram. This was the vertebrobasilar junction aneurysm. And here, this aneurysm was distal to the origin of the pica. So one need to understand from what is the actual origin of the aneurysm. So for this kind of aneurysm, this is dissecting aneurysm. For this kind of aneurysm, if you feel that pica is proximal to the aneurysm, so this kind of aneurysm can be treated either with the FD flow diverter or with the just occluding the artery. The artery is occluded here, and this reverse flow is supplying up to this area, and in this same ipsilateral side, it is supplying the pica. So this kind of aneurysm, instead of putting the FDs where there is need of long-term anticoagulants, and you can get away just by occluding the artery. This is one more PC aneurysm where aneurysmogram was taken and artery was occluded with good distal circulation. Then one more PCI aneurysm where the artery was taken, and suppose this coil compaction is one of the complications of any aneurysm. Coil compaction means the coil is compacting towards the sac and recreating the neck again. So to see that in follow-up, you should, at the end of the procedure, you should take the plain X-ray where you can see this coil mass, configuration, the morphology of coil mass, and in follow-ups, you can repeat the plain X-rays and you can compare with the X-rays rather than going for the DSA or the MR angio or the CT angio as a first go. And if required, you can go ahead with the angiogram. In some cases, you can save the distal PC also for this kind of aneurysm, and medially directed, you can get good neck, and you can, if the first coil is, you can deploy good first coil with a good basket, you can save the distal PC. This was a 15-year-old boy, and who had the superior cerebellar artery. You're seeing the two cerebellar arteries here, the single cerebellar artery. So if This kind of aneurysm, they are many a times they are associated with many morphological variations, and this was partly thrombosed as well. And here the hardware which we used was 8 French femoral introducer sheath, 6 French infinity, that is long sheath. Then Fargo Max was the distal access catheter. Then headway duos, again microvention, it was 165 centimeter, and 018 microcatheter was used because it was so small artery which you could appreciate. So this is the angiogram where you can see this is the distal access catheter, this is a microcatheter, and this is the aneurysm. This part was thrombosed. So you are seeing this kind of morphology and this so small artery. So with this all hardware, we went in and put some coil. Not very compact density is required, and after some time just waited that since do we really need more coiling and all, but this showed could just by putting one coil you get the good result and total occlusion of the aneurysm. Sometimes you just wait for this kind of aneurysm for few minutes and you will find that one coil is doing good work for you. Another case, 27-year-old male who presented with occipital headache and this left SC aneurysm. You need to understand the hardware for this distal kind of aneurysm. Taken the distal access catheter, which is now available, and you can take these catheters right into the basilar artery. This catheter is in the basilar artery, and you are seeing that there is this aneurysm is again very different morphology, irregular shape. And we took microcatheter in this, and that was again the microvention, and just by this kind of cannulation of the artery is not so easy with this angle and all. So one need to see the architecture, what all angle is there at the vessel or aneurysm in relation to the parent artery. And while making various attempts, even just by putting the microcatheter and leaving and selecting the coil and all, we could see that repeat DSA showed that the artery was occluded and the aneurysm as well. Sometimes so small perforators or so artery, they can get occluded just by the catheter or the wires. Then another case, interesting case of 32-year-old lady who came to us in grade 4 SH, and she was intubated, tracheostomatized, and we did the angiogram and vertebral angiogram right-sided, and we saw that there is an aneurysm. We were not sure whether it is arising from the vertebral artery or there is some aneurysm from the ICA also. For this kind of aneurysms, you require super selective angiogram. And when this ICA was cannulated, this aneurysm was actually from the postmeatal segment of the ICA, not from the basilar. This was appearing as if it is arising from the VA, but actually this aneurysm from the postmeatal segment of the ICA, then different loops. Then at the surface there was small some AVM also. So we thought we can coil all these aneurysms, but we could only coil just one aneurysm, proximal one, and that too not complete occlusion. So if you see the anatomy for this kind of aneurysm, for ICA, distal ICA, for proximal ICA it is difficult, but now this was distal ICA, means it is premeatal or postmeatal segment. So it was postmeatal segment, and then it was coming onto the cerebellar surface. So these are the aneurysms which are better operated, better treated by the open surgery than endovascular surgery, where you have many pathologies. And when you see the CT angio, you are likely to get the aneurysms. You don't require the extended suboccipital approach also, the far lateral approach also for these kind of aneurysms, because you are seeing one at the foramen magnum. So you need to open the cistern in the midline, and at the surface we found this aneurysm, small aneurysm. While cutting the dura, we coagulated the AVM also. And you can see that this is aneurysm which was buried and which was lying on the surface of the cerebellum. This big aneurysm, which was clipped, And the aneurysm is just partly coiled. You can see that it was clipped and coil mass was used. So this was the post-operative, this is pre-op, and this was a post-operative angiogram of this lady. And I happened to see this lady in the OPD walking and talking. So it is not posterior circulation aneurysm. If they are grade 4, grade 3, we should always attempt to go for the surgery, treat the hydrocephalus, treat the aneurysms, and many a times they survive also. Then they may present with the multiple aneurysms, with like this patient who had ICA and who had anti-communicating artery aneurysm along with the superior cerebellar artery and basilar artery junction aneurysm, which was simply coiled in this case. Then, like besides aneurysm rupture during the surgery, ischemia, the ischemia just after coiling, you should wait for some time. It's not that just coil and pack up. Wait for 5 minutes, 7 minutes, 10 minutes, that some undo is not happening. And we were lucky to see this. This was the patient where there was aneurysm of SCA basilar junction. And at the end of the procedure, we saw that this BCA was not filling up. And immediately on table, we recanalized the artery, and you can see that this PCA was filling up. And this patient came to us after 1 year without any deficit. So it is very essential to detect, to find the complication happening on table and treat them on table. So to conclude, many anatomical variations happen in posterior circulation aneurysms. Hardware knowledge is very, very essential. And majority of posterior circulation other than basilar tip, they can be managed by coiling. Coil gives you very good remodeling of the aneurysm. That gives you scope because it moves all around different crevices of the aneurysm. Follow-up of these cases is very essential because still we don't know what will be the final outcome. Safe and long-lasting endovascular treatment should be sought, and open surgery may be option for few of these cases. Thank you.
Thank you, ma'am. It was a very, very, very illustrative and exhaustive lecture. See, the 3D DSA has really revolutionized the management plan for all posterior circulation aneurysms by endovascular route. That is one thing I want to add up. And then once if you are a hybrid surgeon, the patient gets a good benefit. So anything, Paritosh?
I agree. Actually, our cath lab is in the process of installation. So hopefully we'll be able to show all 3D images now onwards.
Good, good.
I think great lecture, Doctor. I think we will probably start using with basilar apex aneurysm, which is very short, and that obviates the need of both putting stents in the vessel and putting them on antiplatelets and putting complex coils, which is more difficult than the other ones. So these are great devices, Contour and Web, both of them. And yes, I agree with you that most of the posterior circulation aneurysms, if there is no other problems with the patients and things, it should be treated with endovascular methods. There is, in this modern era, there is really zero doubt in this, in making this statement. So I think more and more neurosurgeons should learn these techniques. These are not very difficult techniques. You should do much less difficult than skull-based surgery. So, and with modern techniques, modern catheters, you can do a great job just if you're very, very careful. And of course, most of them, not all of them, most. So yeah, keep an eye on intrasaccular devices, keep an eye on new stents. And if I have to see, except for probably pica and SC aneurysms, which are probably a good surgical technique, surgically, basilar trunk, basilar top, those aneurysms should always vascular technique, if there is no other. So that is what I would say.
Anil?
Yeah, yes, sir. I would like to invite other panelists for the comments.
Girish has some work and he said that he is.
Yes, yes, sir. He has left, sir. He has left.
Okay.
Sir is there,
for
but
me, I cannot show my video, but I'll just
yes, sir. Yes, sir.
want to put 2 points. One thing is in coiling, there are disadvantages, particularly basilar. There may be incomplete coiling, there may be over coiling, there may be residual neck. That is one thing. And in pica aneurysm, when you are going for lateral, you also one has to be very careful, like ACA, PCA drilling. Jugular drilling is very important, very carefully one has to do. The rest is okay. We are evolving, and I congratulate all the speakers and the panelists, Dr. Paritosh, Dr. Girish, Dr. Sai, listeners on behalf of CVSI, and a great congratulations to Dr. Anil for continuing hard work to keep this webinar go on. Thank you all.
Thanks very much.
Thank you.
Thank you.
See you all. Bye.
Thank you, sir.
Thank you.
Thank you very much.
Thanks.
Good night, Anil.
Good night, sir. Good night.
Sir, can I end?
Thank you. Yeah, you can.
Yeah, Akhila, you can.
Okay.